trigger warning. Why is stillbirth a higher chance of gestational diabetes compared to women who don't have gestational diabetes? Let me know in the comments below if you had any of this explained to you during your pregnancy, maybe the reasons why or the actual statistics. So firstly, let's take a step back. Gestational diabetes impacts about 2 to 8 per every 100 births, and it is increasing globally, the rates of gestational diabetes. This is for several reasons. For example, obesity rates increasing, maternal age increasing, but also there are links even to climate change and heat waves. So during pregnancy, there are lots of hormones, but for some women, those hormones can actually make insulin resistance more likely. And that's where the gestational diabetes comes in. So when we have sugar in our body, insulin comes out, and it means that our blood sugars don't go too high. And insulin resistance makes it harder to be able to control those blood sugars. And too much sugar in your blood is not a great thing for you, but it also means that more sugar is going through the placenta into the baby. Now, in terms of risk factors and screening, I've done a previous video before. Go and check it out in the antenatal series. Now, as a starting point, type 1 and type 2 diabetes and the impact on stillbirths and stillbirth rates is different to gestational diabetes. If you have type 1 or type 2 diabetes, there's a really good fact sheet on the Tommy's website. Go and have a read of it because sometimes there can be impacts on the placenta, which is where the increase in miscarriage and stillbirth for women with type 1 or type 2 diabetes pre-existing to pregnancy can occur. So in terms of statistics and rates of stillbirth with gestational diabetes, this is a good study that you can go and have a read of. It's a 2012 study undertaken in the United States. They found that the chance of having a stillbirth without diabetes was 12.7 per every 10,000 births between 36 and 42 weeks, compared to women who had gestational diabetes at 17.1 per 10,000 births between 36 and 42 weeks. And the chances increased, but not by a huge amount. So not a huge amount when you consider that's an extra 5 per every 10,000 births, which are complicated by gestational diabetes compared to women who did not have gestational diabetes. But the most recent research shows that if diabetes is diagnosed and it is treated appropriately, there is no increased chance of stillbirth at all, whether you have gestational diabetes or not. Again, this is a study that you can go and have a read of. And in this study, they found that the women who were diagnosed with gestational diabetes had the treatment had no increased chance of having a stillbirth compared to women who didn't have gestational diabetes. However, for the women who didn't have any screening in their pregnancy, for the women who are at risk of developing gestational diabetes, they found a significant increase in the chance of stillbirth in these cases. So the physiology isn't 100% known why the increased chance for gestational diabetes and stillbirth is, but we have lots of different theories. And if we think about the physiology of how glucose is metabolized, how glucose is used and broken down, and how it helps our babies to grow and go through the placenta, then we might be able to explain and understand why the chance of having a stillbirth is higher with undiagnosed gestational diabetes than when it's diagnosed. So physiologically, our placenta is the thing that is providing all of the oxygen, the transfer of nutrients, the transfer of glucose, everything that baby needs. Everything that baby needs to grow, so the oxygen and the glucose, helps baby to grow and thrive throughout that pregnancy. The placenta is literally the tree of life. But what can happen is if mum has too much sugar running around her body, so this is what we call hyperglycemia, too much sugar going around the body, because the insulin isn't able to bring those levels down, so she's not able to control the glucose. Lots of sugar will be going into that baby. What can happen as a result of that is that the baby now has too much sugar running around their body. Now, one of two things can happen, because what happens with too much sugar is it makes our blood more acidotic. Is either your baby will start laying down lots more fat stores, so that can lead to something called macrosomia, so the baby grows too big in pregnancy. That can also lead to things like polyhydramnios, so lots of fluid around the baby because they're having to use their kidneys much harder to try and get rid of some of that sugar that they've got an excess amount of. That polyhydramnios can also lead to a baby not being engaged in the right position, which can increase the chance of cord accidents. But it can also increase the chance of a baby not engaging well during the pregnancy and flipping and moving a lot more. And on the other hand, that acidotic blood can lead to the baby becoming much more distressed during the pregnancy. Acidotic blood is not a good thing to have. And what can potentially happen is the baby actually decreases its growth, stops growing, maybe stops moving, becomes distressed inside because acidotic blood is not good. It doesn't help us in any way, shape or form. and it can lead to ketosis, so where the body starts breaking down fat cells. And it's something that we worry about with women who have got diabetes in going into something called DKA. And too much sugar running around anybody's body, even in adults, is not a good thing. And it's why with diabetes, hyperglycemia can be fatal for some people, which is why we monitor blood sugars so closely. And the reason we offer screening to the women at the greatest chance of developing diabetes is because if we screen for it, we can offer treatment, whether that's through diet, metformin, insulin, maybe a combination of all of those. Because in doing those treatments, that helps to bring down the sugar levels in mum's blood. By bringing down the sugar levels in mum's blood, it helps then to reduce the sugar levels in baby's blood to an optimum position where it's not too much, where it's not hyperglycemia at that stage. By doing that, there's less acidosis, so less acidotic blood happening in the baby. Therefore, the baby can grow adequately, the baby can oxygenate adequately, and it means that there's not too much growth, or as a flip side, too little growth happening. It's also why growth scans are recommended and advised to anybody who has gestational diabetes in their pregnancy, and why the timing of the birth usually is optimised around about 38 weeks, somewhere up to 40 to 41 if their control of the sugars during pregnancy has been really adequate and the mum's maybe just had diet to be able to control that. Hopefully that's explained a little bit about gestational diabetes. There are some great accounts to follow on diabetes that I will link below, who are the experts in this field. I know bare basics as a midwife, I know bare basics of physiology, but there are lots of accounts who know diabetes inside out because it's such a huge, complex topic. I'd also recommend the AIMS Gestational Diabetes book as well to have a read of for all of the available evidence and research on this particular topic.